Our first speaker is Mark Ebell. He's a professor of epidemiology and biostatistics at the University of Georgia. But he's also a real doctor, a board-certified family physician. Many of you might know him as former editor of the Journal of Family Practice and current deputy editor of the American Family Physician. But he was also a member for years for the United States Preventive Services Task Force, exactly from 2012 to 2015, correct, Mark? I would like to mention two specific points about Mark's life. First, Mark lives in Athens. Now, you all know Athens with the Acropolis and Sirtaki dance all the time. So he must have a wonderful life. Unfortunately, his Athens is not in Greece, but in Georgia, the place where the university is situated. Mark is not an absolutely genuine American because he was born in Montreal, Quebec, Canada. And as such, he is completely innocent for the tweets of his new president. So this is an apology I offer to you. The title of his lecture deals with a diagnostic uncertainty which frequently occurs in every family practice. Respiratory tract infections, the role of point-of-care tests in the United States of America. Mark, it's your turn.
Vielen Dank. Ich bin nicht nur Kanadier, ich bin auch Deutscher. Mein Vater war von Berlin, meine Mutter war von dem Rheinland. Und ich sprach Deutsch, nur Deutsch, bis ich ungefähr 4 oder 5 Jahre alt war. Dann habe ich ein bisschen Englisch gelernt. My lecture, however, will be in English, and because I was asked to do it in English. Let me just pull it up here, I think. And I bring greetings from our new masters in Washington, D.C., our overlords. There we go. Okay. University of Georgia, where I teach, Athens is actually a lovely town. It's a little smaller than the one in Greece. We have fewer riots, though. And it's a lovely college town. It's actually very much like Göttingen, about 100,000 people. It's about 200 years old, a little younger than Göttingen, and about 30,000 students. We have a medical campus now for the past 6 or 7 years. I teach medical students. I do research. I teach public health students, so I really enjoy the life there. We live. The Innenstadt von Athens is very livable and nice, unlike the Innenstadt in many similar U.S. cities. We have, unlike Göttingen, Universität Göttingen, we have a football stadium with 100,000 seats, and that's a picture taken there with our mascot, hairy dog, haariger Hund, würde man sagen. So I'm going to talk a little, I was asked by Ildiko to talk a little bit about point-of-care testing, also called near-patient testing in the UK. And so this is something that I've done some research on, and I'll share a little bit of my research, but also talk about work others have done in this area, and compare and contrast the U.S. system with what's happening in Europe. I had a lovely visit to Matthias Löber's practice this morning and learned a lot about how care is delivered here. Really enjoyed that very much and learned a lot, and it gave me a lot to think about. So Thomas Willis described tasting urine as a test for glycosuria. That was actually the first, I would say, near-patient test. He described the flavor as wonderfully sweet, as if it were imbued with honey or sugar. So fortunately, we have moved on a bit since then, and we have a somewhat more modern ways of testing for glucose. In the United States, there's we call it the CLIA Act, and it's a way that the FDA, the Federal Food and Drug Administration, organizes laboratory testing, and they have set up a category, a fairly large category of tests that are called waived, or waived means you don't have to have any inspections or frequent visits from health inspectors. If you're a GP in the U.S., family physician like I am, you can have a laboratory in your office and do these tests. They're considered to be low risk and accurate enough to be done in that setting. What I show here are some of the tests. It's not all of them, but some of the tests that you will see in a typical GP office. And I think this is interesting because it's quite different in some ways from the practice in the UK and Germany and elsewhere. Urine dipsticks, almost everybody. Fecal occult blood testing, very commonly done, and interestingly, many physicians still do a rectal exam as a screening test for colorectal cancer and then take the stool and wipe it on the card. Guidelines say don't do that because of the trauma. You get many false positives, yet many physicians, the majority actually continue to do that. Sometimes it can be very hard to change bad habits, as we all know. Rapid strep and flu testing, very, very common. I'll talk a little more about that later. Testing for blood chemistries, transaminases, drug testing, INR, prothrombin time, even rapid tests for HIV, hepatitis C, Helicobacter are all done in many laboratories in the GP setting in the United States. So it is very common. For example, the rapid strep test, I didn't see one in Matthias's office, and I don't think they have that testing. Perhaps I can be corrected, but I think it's not used in very many practices in the U.S. It's almost every patient with sore throat in the U.S. gets a rapid strep test. So there are practices that have protocols in place, actually, that every single patient with a sore throat gets a rapid test for strep, even before they see the physician. I think this is ridiculous, but that is a common practice. Influenza, during influenza season, if you go to one of the very large, what we call urgent care practices in my town, every single patient gets a flu test. They get a nasopharyngeal swab, the kind that goes back and it seems like it's disappearing into your brain, and then they pull out and the patient tears up and they do the rapid test for influenza. And that's done on all patients before they see the physician. So all diabetic patients may get an A1C, for example. Now, this varies quite a bit. In my practice, I still see patients a small portion of the week. I see the patient, and then I decide whether or not to order the test. And in fact, a lot of my work revolves around how can we use the signs and symptoms to more intelligently order these tests. How can we identify patients for whom there's still a decision to be made versus it's been ruled out or ruled in? Why do we do so much testing in the U.S.? It's not too hard to figure out. It's what we call a profit center for many practices. What we see there is I went on Big Box Medical, and you can buy 25 Strep A test kits for $33. Medicare reimburses $16. So you can imagine there's quite an incentive financially to do more testing. Typically, the test is reimbursed at a significantly higher rate than what the physician pays for it. It's not always 15 times as much. Insurance companies typically reimburse the private insurance $7 or $8, but it's still quite a profit potentially. Behavior, my sister is an economist in London, and she studied at the Universität Bonn for her master's degree, and she says behavior follows incentives. And I think this is true in Germany as well as in the US, but you have probably different sets of incentives. So what near-patient testing are physicians doing around the world? This is an excellent article. Matthew Thompson, who's now a U.S. colleague in Seattle, was one of the lead authors. I know a number of the other names, Jochen Kels, John Hickner, a good friend of mine who I was just with last week in Chicago. And they did an excellent multi-country survey to show what are doctors doing in their practices. 2,770 primary care physicians in 5 countries. Sadly, not Germany. Terrible oversight, but they apparently couldn't do this in Germany, or didn't do it in Germany. So it is interesting, though, if you look at the total, the average across all 5 countries, very traditional things like urine dipsticks, urine pregnancy test, the blood glucose, INR, and hemoglobin are very commonly done in all countries. On the other hand, if you look specifically at what the U.S. does more than Europe, rapid strep, rapid flu, and fecal occult blood testing are very common, 60 to 83% in the U.S., and only 1 to 15% in these other 4 countries. And it raises the question of why, and we'll discuss that just a bit. I also thought the most interesting question that they asked in this project was, what do physicians want? We know what you're doing, but what would you like to have in your practice? And it's interesting, these are actually more sophisticated tests. They're quite specific for particular conditions. They're more contemporary tests, troponin, D-dimer testing. Chlamydia, interestingly, was one of the point-of-care tests wanted. BNP for heart failure management. And there's actually pretty good evidence out there that these tests can improve the efficiency of care. CRP has been shown in Jochum's and other studies to reduce antibiotic prescribing that's inappropriate. Troponin is a part of many rapid MI rule-out protocols. D-dimer, of course, is useful in a low-risk patient for ruling out PE or DVT. So you can imagine in a rural setting, when I practiced for a while in a small town in Georgia where it was about 15 or 20 miles, 25, 30 kilometers to the x-ray or to the emergency department. So if I could rule out a DVT in my office, the patients would be very grateful, and it would save them a trip and also be very cost efficient. C-reactive protein is interesting to me in particular because it's part of many protocols to do with respiratory infections, and unfortunately, in the United States, it is not one of the CLIA waived tests. And I spoke with somebody at FDA, and they said, well, we're not sure you GPs are, they didn't quite say this, but reading, as we say in the U.S., between the lines, they seem to think we weren't quite smart enough to know what to do with the information, and they were worried that it would lead to too little antibiotic prescribing for people who really needed that antibiotic, which is absurd on its face. We prescribe, if you have a chest cold, in the U.S., you have a 75% chance of being given an antibiotic. Half of those or more are levofloxacin or azithromycin broad-spectrum antibiotics. So there's so much inappropriate prescribing. That's the least of my worries that patients won't get an antibiotic. So how do we pay? I think that gets into some of the reasons why the near-patient testing is used at such different frequencies. In the U.S., insurance reimbursement, basically, if I think it's needed, someone will pay for it generally. It's very unusual in fact, I've never had an insurance company question one of these near-patient tests. They may question an MRI of the head, which is quite expensive, but they won't question these. In the UK, near-patient testing is not reimbursed separately. And I quizzed some of my friends in different countries, Theo Verhey in the Netherlands, and Mike in the UK, and Ildiko here, and Nicola Hen in Switzerland. Netherlands only and Germany only reimburse a very specific, narrow range of tests, and quite modestly, actually, in terms of the amount of money. And Swiss is more similar to the US in that the practice purchases the tests and gets reimbursed by insurance, and many rapid tests are used, and most GPs have a lab. So US and Swiss are a little more common, have a little more in common. So what do our patients think about this? There was a couple of studies, one in the British Journal of General Practice, another Matthew Thompson did, another one in BMJ Open that Matt did, and they talked to patients in the US, they talked to patients in Australia, and the patients think it's a good idea. Patients are often in favor of that. In the U.S., patients love diagnostic testing. They love getting a number. They love their knowing what their cholesterol is every single year because, my gosh, it might have changed in the last 6 months. And so there's a great sense of security in knowing these numbers. 87%, though, preferred not to take an antibiotic if they thought it was safe, and they would put up with a finger stick for a CRP, for example, in order to avoid an unneeded antibiotic. So I think there is potential for educating patients about the value of some of these tests. If you have, for example, lipid testing in your office, which we have, it can be actually quite nice to do a risk profile for a patient while they're in front of you, have the lipid value, not have to bring them back in a week later or 2 days later. And so we can do some nice shared decision making as well. Some of the problems are that it's not always as accurate as we would like. For example, the office Helicobacter tests are specifically recommended against by the guidelines because they're not accurate. But now we have office-based urea breath tests for that. The rapid flu test is only 70% sensitive, so we may miss many patients with flu. Is that important? I'm not so sure. One of my main concerns is that we have these one-size-fits-all strategies where everyone with sore throat or everyone with flu gets a test. So patients with a low likelihood, even if the test is positive, they still probably don't have flu. And if it's a high pretest probability and it's negative, they still may have the flu. So we end up with undertreatment and overtreatment. It also increases costs and may also drive an expectation that we'll always get a test every time we come in. So some questions that I have are, can we use these near-patient tests intelligently to target prescribing? There is the occasional patient with a cough that might benefit from an antibiotic. Patients have pneumonia, after all. Patients with sinusitis, probably a third, have a bacterial cause. Can we identify those patients and target the antibiotics and reduce the inappropriate prescribing that way? And maybe if patients and physicians are more confident in the diagnosis, maybe there's less chance of a patient coming back 5 days later or 3 days later if they're not feeling perfectly well again. So can we improve practice efficiency in that way? So this is the most complicated slide that I have, and it shows the thresholds for decision making. On the top, it shows a test threshold and a treatment threshold. Below the test threshold, the probability of, let's say, influenza is low enough that you wouldn't test or treat. You just say, I don't think you have flu. Above the treatment threshold, it might be high enough that you'd say, I think there's a very good chance you have the flu, and you've only had it for a day, and I love prescribing Tamiflu, so I'm going to give you Tamiflu, or oseltamivir. In the middle, that's where we need testing. That's where we need more information in order to push us above the treatment or below the test threshold. And that's where potentially we can combine signs and symptoms with near-patient testing in a more intelligent way. We developed a clinical decision rule called the flu score, and it divides patients into low, moderate, and high-risk groups, 6, 30, and 58% likelihood of flu. And if you have that 6% likelihood, you don't need a flu test. If you have that 58%, arguably, you might not need one either because the doctor might just conclude you probably have flu. It's only in the middle that you might need the testing. So this was a way, I'm thinking, to perhaps reduce the very large volume of testing we have in the U.S. I talk to my European colleagues and they say, why are you doing those tests at all? But we're doing them. So I'm trying to develop strategies for helping American physicians reduce how much of that they're doing. So a study I did with Jens Hansen from Aarhus, we looked at near-patient testing combined with signs and symptoms to try and diagnose bacterial rhinosinusitis. This is an old data set, but it's a really very nice data set because 175 typical GP patients, 2/3 of those he approached entered the study, which is a very good recruitment rate. They all had signs, symptoms, CRP, SED rate done, and they all had a CT, and if there was any hint of fluid, they all had a puncture, and fluid was drawn out and cultured. And so that's quite a good reference standard for sinusitis, and about 1/3 had bacterial sinusitis. So we did a logistic regression, the usual thing. We used the beta coefficients to assign points, and we found that the single best predictor was the C-reactive protein greater than 15. Of course, this is the test I can't use in the U.S. because I'm too dumb to know what to do with the information, but maybe that'll change. You all could potentially use it. There are 5 very typical signs and symptoms, and by combining them into a point score, we can develop a little clinical decision rule. The low-risk patients, 16%, moderate risk 50%, high risk 73%. Over half of patients could be put into the low or the high risk group. It's only the middle where you might actually have to use some clinical judgment potentially and talk to the patient about other symptoms, double sickening, things like that weren't in the data set. Area under the ROC curve was about 0.72. Another study that I did not do, but that I greatly admire, Saskia van Vugt, was the PI, was the GRACE study done in many European countries. Some of you may have even participated in that. It was a large prospective primary care study of patients with acute lower respiratory infection, 2,800, of whom about 5% had pneumonia. So I think that's typical in GP practice. Created a model. And again, it was the combination of signs, symptoms, and the CRP, a near-patient test, that was the best model for predicting pneumonia. And, it's quite useful if somebody is high risk, 18% had pneumonia. If they're low risk, less than 1%. So again, that helps you with your decision making. There's a fairly large group in the middle that have a 4% likelihood sort of average, but at least for the low and high risk groups, it can help you with your decision making, I think. I would certainly want a chest x-ray on the high risk, and I would certainly rule it out comfortably in the low risk. This is an ROC curve The upper left corner is where you want to live in an ROC curve. That's a perfectly accurate test. And the curve, the closer the curve is to that corner, the better the test. This is looking at different models. And the main thing I want to point out, the red dotted line is the signs and symptoms model plus CRP. The other lines don't have the CRP. So the CRP significantly added to the accuracy. So I think this is another example of intelligently using the CRP, a near-patient test, to help diagnose and then hopefully make a better decision about selecting a chest X-ray. We have an ongoing study right now. That's the University Health Center at the University of Georgia. It's quite a large clinic. They see, I think, 30,000 visits a year, about 3,000 patients with flu-like illness. 1,500 with flu-like illness, 3,000 with sore throat. So it's a good place to find lots of patients. We recruited 300 patients within 5 weeks for our study. So what we did was, this was funded by Roche, who makes a point-of-care PCR test for influenza. It's about 98% sensitive and specific. So my thought was, does having this new information, this highly, highly accurate test, improve clinical decision-making? What currently happens when you talk to doctors in the U.S., many don't use the flu test, which is fine. But if they use it, many of them don't believe the result. They may have in their head, I think this patient really has the flu. The flu test is negative. I'm still giving them Tamiflu. Or the flu test is positive, but they look so sick, I don't believe it, I'm going to give them an antibiotic. So there's a lot of irrational decision-making, I think, that could be happening. So we're comparing in our study 300 patients whose care was guided by this highly accurate test, with 450 who received usual care. Maybe they got a flu test, maybe they didn't. We gathered prospectively signs and symptoms, duration of illness, and 1 week follow-up to see how they were feeling. We also were interested in seeing, does this information, this confidence in knowing you do or do not have flu, change behavior? Are they more likely to isolate themselves, avoid buses, avoid cafeterias and places where they might spread it? So that's kind of a secondary aim. And we're also using the data to try to validate the flu score that I mentioned previously. Sadly, we just completed data collection and we haven't analyzed it yet, but if you come to the GRIN meeting or to the NAPCRAG meeting, I'll be happy to share the results with you. So where should we go from here? Do we want to, I would like to see less of a profit incentive in the U.S. at least. Perhaps some places like the U.K. maybe need a bit more of a profit incentive in order to use some of the tests that might actually be valuable. I think studies are needed not just on the accuracy of these tests, but on their impact on care. Do they change physician behavior, change prescribing? Do they change patient behavior? Do they call back less? Can we save time? Can we make practice more efficient? I think we need to think critically. Do we really need in the U.S. HIV testing at the point of care or Hep C, or can we do some of these things just as well with a 1 or 2 day turnaround? I think the answer is probably yes. We have too much profit incentive where I am from, and so that drives a lot of testing to the point of care where it may not be quite as efficient or cheap. I think, as I pointed out, integrating near-patient testing with signs and symptoms with your clinical expertise is very important, and I think it's much more productive than either one alone. And so potentially rules for UTI, for strep, for other common acute conditions may be quite helpful, but I think integrating that near-patient testing, there are some for UTI now that integrate, obviously, urine dipstick with signs and symptoms. And I think definitely avoiding these one-size-fits-all protocols. I'm not sure if that's ever done here, but in the U.S. it's quite common, and I dislike that whenever I see it and in my practice. So where do we go from here in the future? I think we should be anticipating what's coming. And there are companies working on these rapid cycling PCR tests, polymerase chain reaction or other molecular tests, and they're very accurate, but they're very expensive. And not every patient needs one. And I'm concerned that it will get to the point where we, again, in the U.S. at least, we get the technology, the machine that goes ping, and we adopt it too quickly without really understanding how and when to use it. I think there probably are some patients that might benefit from these tests, but they're the ones in the middle, not the low risk or the high risk. And so I think a lot of work still needs to be done to figure out who needs these new tests as they're developed. I think integrating these test results with what we already know about the patients and our health record, building the decision support tools like the flu score or like the strep score into the health record, so it's providing the decision support within the record, not separate from the record, is very important. And then finally, in the U.S. at least, we're starting to see some experiments with delivering basic care for common conditions in pharmacies, in drugstores, in apotheken, where they have a nurse who will do a protocol for sore throat and take a rapid strep test and calculate the strep score and then prescribe something. So that's beginning to roll out there, perhaps also in other countries. Thank you very much. I've enjoyed sharing a little bit of my experience in the U.S. with you, and I'd certainly welcome any questions if we have time. I'm not sure how long we have. Auf Deutsch oder auf Englisch? Macht mir keinen Unterschied. Ja.
Thank you very much for your talk. What do we know about the influence of point of care testing on patient satisfaction and on the pressure patients may take on doctors? Do doctors feel there is less pressure when they use the point of care testing? For example, when a patient comes with a cough or a common cold.
So are the patients satisfied with that? I think generally, yes. One of the questions that we're asking in our study is among the patients who did not get near-patient testing, their overall satisfaction with the visit. So we might get a bit of a clue to see if it's greater if they received the near-patient testing. We're interested in that. The studies that Matthew Thompson did and that was the other one in the BJGP, the patients were generally quite satisfied with the option of having near-patient testing. In many cases, just convenience. It saved them a trip to the laboratory, which is a drive across town. For many older patients, especially in the U.S., we don't have the public transit that you have here, and so they have to drive themselves or rely on someone to drive them. So you could imagine if a patient sees me and I say, you need a blood cholesterol test and an A1C, then if they have to make another trip to a laboratory and then another trip back to see me a week later to discuss the results, they prefer the convenience of being able to just do it during that same visit. They go out in the waiting room, we run the test, they come back in and we discuss it, and then they're done. So I think there's some advantages for patients. I think we just have to be careful about why we're doing these tests, that it's for patients and for their betterment and their satisfaction and not just for a profit motive. Other questions? Yes?
I'm a family physician. And my question is there any evidence that taking the patient's temperature is inferior to CRP testing?
Is there any evidence that a patient's temperature is inferior to near-patient testing? They do actually, or CRP in particular.
I'm always taking just the patient's temperature
Yeah.
here, and I'm just asking myself whether it is cost efficient and whether the interruption in the workflow is worth to test the CRP. Do I get better information?
Yeah, there are a couple of things. The clinical decision rule that Van Vogt developed for pneumonia includes, I believe that fever is one of the components of that and CRP. So in the multivariate model, they were independent predictors, so it provided additional. So I showed you that ROC curve, it was greater with the CRP rather than the model that included temperature and several other things. So that's the other thing is there have been a number of studies done, there's a Cochrane review as well, that patients are more comfortable not taking an antibiotic if they're shown a CRP result. They say the number was 5, this makes it much less likely, you don't need an antibiotic, and there was satisfaction with that as well, and it reduced inappropriate prescribing rates. Any other? Mike?
Yeah. So in the UK there has been a move to pharmacy testing for near-patient testing for strep. But there's some work that shows that only 1 in 6 patients actually see their doctor, and there's a potential that if you remove the barriers to consultation, that more people with sore throats will consult, and that you'll get more antibiotics being used rather than less. I don't know if the same kind of, if that information is available in the States.
Yeah, there are some, there are clinics in pharmacies that are doing I can't remember the company, but it's a large chain. They have pharmacies all over the United States, and they will put a nurse in there. They will have the nurse assess the Center or strep score, and then if it's in the mid-range, they do a rapid strep test, and they deliver care that way. And I think they've reported studies, and the prevalence of strep was similar to that seen in GP practices. It was in the 15 to 20% range for kids, 5 to 10% range for adults. So it was similar to what the GPs were seeing. Now, they still have to pay for that, but it's a lower barrier to entry. You can just walk in and wait 10 minutes and be seen. So I don't think so. I think it's absolutely right. If it was zero barrier to care, if patients were doing it at home without having to have any barrier, I think exactly that might happen. You'd have a lower prevalence, and the prediction models probably wouldn't work. How much time do I have, Ildiko? Are we? I'm happy to take another question, and then you can let me know.
The organizer said that you should discuss in common after the last lecture of this block.
Oh, okay.
So, if you agree, then.
Yeah.
I've got a question. Why would you want to make a difference if somebody has a strep throat or a viral throat? I believe antibiotics don't change a lot, even if you're stuck in your throat. So patients are that rare, they don't have traumatic fever anymore.
I know.
Why are you so curious and using the strep test or anything?
Not me. I know. I think, are you from Norway by any chance? No. But certainly it varies a great deal, and in different countries people worry a lot less about it. We worry more about strep than any country in the world. The pediatricians, you think the family docs are, but the pediatricians, they insist that even if that rapid test is negative, you still send a throat culture out to the laboratory, because my God, you can't miss one case of strep. And so I agree. I think the studies, there's about a 1-day symptomatic benefit, not that different from Tamiflu, which is about a 1-day difference. There perhaps is a little bit of reduction in transmission, but the kids have already spit on everybody they're going to spit on by that point. So I agree, and there's rheumatic fever is a reportable event in our country. So I agree. I'm just trying to reduce the use of these in any way possible. Anyway, thank you again.